Can I start, sir?
Yes. Good morning and warm welcome to Online Anesthesia, postgraduate teaching program and Zoom platform sponsored by Akila and hosted by A1 Logics and simultaneously aired by Anesthesia TV. Today we are starting with the first session of obstetric anesthesia. The first topic is physiological changes of pregnancy by Dr. Akilandeswari. She is working currently as a professor in the Department of Anesthesiology at the Ramachandra Medical College and Research Institute. She has graduated from SRMC RA in 1995 and had done MD in Madurai Medical College. Her area of interest is pediatric anesthesia, obstetric and airway. She is an active member of ISA and executive member of AOA India and IAPA Tamil Nadu. She has written chapters in books Post-Caesarean Analgesia, Transdermal Drug Delivery, Awareness Under Anesthesia, Management of High-Risk Obstetrics. She was the scientific committee in charge for the national AOA conducted in the Chennai in 2019. Thank you. On behalf of Online Anesthesia, we welcome you, madam. Over to you, madam. You can share your screen. Yes, madam, you can start.
A very good morning to all of you. And I thank the entire Dr. Edward Johnson and the entire crew members who have been doing this wonderful job of teaching postgraduates, especially in this morning session of Sunday. Good luck to you, Dr. Edward Johnson, and all the other crew members. Talking about physiological changes in pregnancy and their anesthetic implications, let us okay, so the outline of my talk is going to be what are the changes that are occurring in the course of pregnancy, why do they occur, and what is their course with regard to first trimester, second trimester, and third trimester, and do we have any, why do we need to know these, and what are the implications for the anesthesiologist. When you look at why these changes occur, mostly these are because of the hormonal changes, namely the estrogen, the progesterone, the relaxin, and the sympathetic system, which all gets activated during pregnancy. These hormonal changes act on different parts of the body, namely the cardiovascular, respiratory, and all the systems in the body. Apart from this, the mechanical effects of the growing uterus and the fetus also contributes to the anatomical and physiological changes that are occurring in all the systems of the body. Why do we need these changes? Basically, these changes occur to meet to the metabolic needs of the fetus and the mother. These changes, they start as early as from the 4th to 5th week of gestational age. And when you look at the resolution of these changes, they vary. They do not go simultaneously or in a sequential manner. They vary between 16 hours to 12 weeks postpartum. So for all the changes in pregnancy to wear off, it really takes 12 weeks of postpartum. When you're going on to the initial thing, how much is the how do we first looking at the changes which occur with the body weight and composition? The weight gain during pregnancy is supposed to be about 17% of your pre-pregnancy weight, or at least 10 to 12 kg is the average weight gain for any normal pregnant patient. Out of this, the uterus and the fetus, they contribute about 4 kg. The blood, the interstitial fluid, and the plasma volume, they contribute around 4 kg. And the new protein and fat, which is being generated to cope up with these metabolic demands in the form of increase in the organ size and in the number of cells, that contributes to another 4 kg. So roughly there is an increase of about 10 to 12 kg in any pregnant woman. So anybody who is going to be little bit on the overweight side is going to be an obese patient, and a patient who is little bit on the obese side is going to be a super morbidly obese patient. So these, as such, obesity has anesthetic implications, and in addition to this, the physiological changes that are going to occur on the pregnant patient are going to add on it. This is the split up of the weight gain. And when we look at the systematic changes going to the cardiovascular changes, now looking at the anatomy of the heart, how is the heart being positioned in the precordium? Because of the growing size of the uterus, the heart is displaced upward and to the left. So when you want to do a physical examination and locate the apical impulse, it is located at a higher level, at the level of the left fourth intercostal space, and it lies in the mid-clavicular line. And the accent, the heart sounds when you look at the S1 is very loud because of the increased blood volume and increased cardiac output which occurs. And there can be S3 and S4 heart sounds can be physiological. So in addition to this, there can be ejection systolic murmurs which are happening in the left parasternal border, which can be flow murmurs, or it could be a pathological murmur which we have to pick up. Then when you take an ECG on a pregnant patient, definitely it shows sinus tachycardia. There can be a short PR interval. Because of the upward shift of the heart, there can be left axis deviation, and there can be T inversion in lead 3. All these changes are physiological in nature. When you consider the anatomy, when per se, what are the morphological changes which occur? There is cardiac muscle hypertrophy. When I say cardiac muscle hypertrophy, there is increase in size of the cardiac muscle cells, and the type of hypertrophy which occurs is eccentric hypertrophy, and it is often a reversible hypertrophy, unlike a hypertensive hypertensive patient which we see normally. And now what is the difference between a hypertrophy which you see in hypertensive patient and in a pregnant patient is that there is no compromise on the size of the chambers. For example, severe left ventricular hypertrophy can lead to decrease in the available volume of the left ventricular size. So this can ultimately result in impaired diastolic relaxation. Whereas in pregnancy, there is no compromise on the size of the chambers, and it is often an eccentric hypertrophy. In addition to this, there is no compromise in the coronary blood flow also, because the angiogenesis is supposed to be preserved. So it is called as physiological angiogenesis and eccentric hypertrophy. When you look at the echocardiogram, the left ventricular wall thickness and the left ventricular wall mass increases by 28% and 42%. It is not only the left ventricle which increases in size, there is also increase in the right ventricular mass. There is also dilatation of all the 4 chambers. Because of this dilatation of the 4 chambers of the heart, there can be mild annular dilatation of the tricuspid valve and the pulmonary valve, which can lead to mild tricuspid regurgitation or pulmonary regurgitation in an echo. These can also present as systolic murmurs in the left parasternal border. So any systolic murmur, so when do we evaluate these patients? Whenever the grade of the systolic murmur is grade 3 and more, or a presence of a diastolic murmur, or when a patient has got dyspnea at rest or unexplained fatigability, syncope or palpitations, you evaluate them for your cardiovascular illness, because most often these patients, they complain of some amount of dyspnea on moderate exercise or on severe exertion, which is inevitable because of the changes that are going to occur in the cardiovascular system and in the respiratory system. When you look at the other changes which are happening, as I already told you, there is increase in level of the estrogens and the progesterone. The estrogens, what do they cause? Ultimately, they activate the renin-angiotensin mechanism, and also they stimulate the aldosterone. So both of these lead to intense sodium and water retention. So this sodium and water retention ultimately results in increase in the plasma volume. The increase in plasma volume, which occurs during the course of pregnancy, is roughly about 50%. But when you look at the rate of change of increase in plasma volume, it starts early at the stage of 4th to 5th weeks of gestation. It slowly raises throughout the first trimester, and then there is a rapid rise in the plasma volume at the start of the second trimester, and it peaks at the early part of your third trimester, where it attains a value of 50 to 55%. And when you look at the total blood volume, that also increases in a similar way, but the volume increase is roughly about 40%. The plasma volume increases by 50 to 55%, whereas the total blood volume, when you see it is increasing by roughly about 40%. So on an average, when you calculate it on the basis of blood volume per ml per kg, it increases from 76 ml per kg, which is the pre-pregnancy level, to 94 ml per kg. So we have got around 30 ml per kg as an extra reserve in any pregnant patient who has crossed around 28 to 30 weeks of pregnancy. Whereas when you look at the red blood cell volume, the rise in red blood cell volume does not correlate along with it, does not parallelly follow the increase in plasma volume or the increase in total blood volume. It follows a mediocre pattern where the ultimate increase is only 25%. This is the reason why there is a little bit, a person who's having 12.5 grams or 13 grams per deciliter of HB to start with will have some amount of decrease in hemoglobin during your first and second trimester, which is often referred to as physiological anemia of pregnancy. And when you look at the central hemodynamics, what happens to the cardiac output? We are bothered about heart rate, stroke volume, cardiac output, systemic vascular resistance, and the filling pressures of the heart. This is how we look at hemodynamics in any patient. So in a pregnant patient, when you look at the heart rate begins to rise by 15 to 20%. And this early rise in heart rate is the first one to be achieved. Even before the cardiac output increases, your heart rate increases. The next thing to occur is around increase in your cardiac output. This increase in cardiac output is because of your, we know that cardiac output is nothing but a function of your stroke volume and heart rate. So what contributes to the early increase in cardiac output is the heart rate. Whereas after 7 to 8 weeks of gestation, if you look at the graph, you'll see that there is a rapid rise in your stroke volume. This rise in stroke volume reaches about around 35 to 40% at the end of your second trimester, and it reaches around 40% around 32 to 34 weeks of gestational age. So the maximum increase in cardiac output of about 50%, when you see, this is attained at around 34 weeks of gestation. what is the implication of this increase in cardiac output? So the maximum increase in cardiac output occurs at 32 weeks of pregnancy. So this increase in cardiac output is primarily brought about by, as I already told you, there is an increase in left ventricular mass. In addition, the plasma volume also increases as told before. So both of it will contribute to increase in end diastolic fiber length. So the blood volume increases by 40%. So the preload to the heart increases, and whenever the preload to the heart increases, the end diastolic fiber length increases, which ultimately results in increase in cardiac output. So it is both the contractility and the increase in end diastolic fiber length, that is the function, which ultimately improves your cardiac output. And what is the implication of this increase in cardiac output at 32 weeks? So any patient who has got a cardiac disease which is not picked up or which has been compensating for over the years can get manifested at this 32 weeks of gestation. So anyone who is coming with dyspnea or new onset of cardiac symptoms around this time, we should need to evaluate them for cardiac diseases. Next, when you look at blood pressures, there is an overall decrease in your systolic blood pressure, in your diastolic blood pressures, and in your mean arterial blood pressures. But the decrease is maximum at about mid-gestation, that is around in your 12 to 18 weeks of pregnancy, there is a maximum drop. Why is there a decrease in this blood pressure? That is because of your decrease in your systemic vascular resistance and your pulmonary vascular resistance, and this is majorly because of the hormonal effects which occurs during pregnancy. Now, the SVR, when you look at it, it is reduced by 20%, whereas your peripheral vascular resistance is reduced by 18%. So, regurgitant lesions, they do compensate and they adapt well during pregnancy because a mildly increased heart rate and a small reduction in SVR is the desirable goal. So these patients, they do compensate well during pregnancy, whereas all the stenotic lesions who have especially a fixed cardiac output, somebody like a patient who's having a mitral stenosis or an aortic stenosis, they maintain their blood pressure based on the systemic vascular resistance. So whenever there is a mild fall in systemic vascular resistance, since it is a fixed cardiac output state, there has to be a tachycardia which has to occur to increase the cardiac output. So which is poorly tolerated by these patients, and hence they manifest with cardiac failure. And when you look at the type of circulatory state, it is called as the pregnant patients are called as the hyperdynamic circulatory state, where the cardiac output is increased and also the systemic vascular resistance is decreased. That is often referred to as a hyperdynamic circulatory state. And over the changes in cardiac output during the pregnancy, we've looked for what happens during labor, during the latent phase of labor. Now, it's very important to look at this graph. How are the changes in the cardiac output? There is a maximum percentage change is around 50%. This 50% change, I told you, it occurs in the early part of your third trimester, and it is preserved the same throughout your third trimester. After that, there is no major change in your cardiac output. Whereas at onset of labor, what happens is there is further increase in your cardiac output, which is around roughly 15% during the latent phase of labor, which increases to above 50% during the active phase of labor, and ultimately it increases to around 125 to 150% during the immediate postpartum period. So why is there an increase in so much of cardiac output? This is because every time there is a uterine contraction, there is blood which is being expelled into the systemic circulation, which is often referred to as autotransfusion. And labor is a very intense physical exercise where you need a lot of sympathetic activity, which often leads to increased amount of catecholamines, and they result in augmentation of your stroke volume and heart rate, which also increases the cardiac output. In addition, once the baby is born, the aortocaval compression is released and there is improved venous return. So increased venous return, enhanced sympathetic activity, and your blood volume increase, all these pushes your patient into a very high state of blood volume, high state of capacitance is needed. So in a patient who has got cardiac disease, what happens is this is the phase where they will go into pulmonary edema. And there can be unmasking of cardiac disease, something like a peripartum cardiomyopathy, or when there is overzealous administration of fluids and syntocin during the third phase of labor, it can trigger pulmonary edema. And so how do we avoid these increase? So this is the major increase in cardiac output that occurs during the latent phase and the active phase and in the second phase of labor and in the immediate postpartum phase ultimately are the reasons for cardiac decompensation. How do we avoid this knowing this physiology? It is advisable to use neuraxial anesthesia during labor and give them opioids so that this sympathetic activity is abolished. So there is a decrease, and also by giving adequate pain relief, you decrease the bearing down reflex, and associated autotransfusion can also be brought down to a certain extent. And then at the end of the birth of the baby, we can give a dose of Lasix, which will improve in improving the increased extracellular water that occurs following labor. And when you look at the distribution of blood flow, what happens is there is, though there is an increase in cardiac output and blood volume and all those things, is the blood flow uniformly increased to all organs when you look at it. There is greater blood flow only to the skin, kidney, and the uterus. So when you look at the uterine blood flow, normally it is around only 80 to 90 ml per minute, whereas a term uterus, the blood flow is around 1000 ml per minute. And the type of flow which you look at it is a low resistance circuit, and there is nil autoregulation. So the perfusion is entirely dependent on your arterial pressures, venous pressures, and your vascular resistance of your placenta. These are all the things that are ultimately going to decide the fetal well-being. So the one point to remember is your circulation, your uterine circulation has nil autoregulation. And so there is whenever there is even a 5 to 10% fall in your MAP or your systolic blood pressure prior to the delivery of the baby, it is very important to treat vigorously the hypotension. In addition, when you look at the blood supply to the uterus, it's around 1000 ml per minute. So in case of atonicity of the uterus, within 2 to 3 minutes, the patient can just get exsanguinated. He can lose around 50% of the blood volume in 2 to 3 minutes. So in no time, you lose your blood, and you don't, because it is a compensated system, you don't exhibit features of tachycardia. Whenever there is a hypotension in a pregnant mother, it means we have missed the bus, and it is a late ominous sign of hypotension. So blood loss. And the next physiological change which occurs in cardiovascular system is with regard to the iotocaval compression. What is iotocaval compression? So as the pregnant uterus comes out of the pelvis by 12 weeks of gestation, and when it is around 20 weeks of gestation, what happens is it presses against the vertebral column, and against which the inferior vena cava and the aorta are lying on either side. Your inferior vena cava is more towards on the right side, and your aorta. Though aorta is a muscular organ which is non-compressible, because of the weight of the uterus, there is some amount of displacement of the aorta which is happening in the supine position, which you can look in this coronal section. There can be complete occlusion of inferior vena cava when the patient lies supine, and there can be displacement of your aorta to a certain extent. And in cases of extreme hypotension, there can be even the perfusion to the uterine can also get compressed. So whenever there is a compression of your IVC, what happens is there is a decreased venous return. Whenever there is a decreased venous return, the preload to the heart gets decreased, and your cardiac output ultimately comes down. In addition to this, your placental perfusion, as I already told you, it depends upon your arteriovenous pressure difference. So when there is a decreased venous return, which is happening at this level, there is a venous pressure which is getting built up. So ultimately, there is an increased venous pressure in the setting of hypotension, which ultimately results in a compromised uterine blood flow, and there can be fetal tachycardia or fetal bradycardia, which can set in during supine position. This changes can get aggravated during neuraxial anesthesia or during transport of patients vigorously. We all tend to miss. So it's very important that we transfer patients, pregnant patients, only in the lateral position, which is very important take-home message of this. And how do we avoid this aortic cable compression? So one method is you position your patient completely lateral when he or she is not anesthetized. So this will relieve the cable compression, and automatically there is improved venous return and your symptoms get relieved. The next thing, especially when the patient is given regional anesthesia and when there is hypotension, you have given vasopressors, you want to relieve the aortic cable compression, it is very important you do a manual uterine displacement. And the other things which can be done are tilting the OR table to at least 30 degrees to the left. It has been shown previously that even a 15-degree tilt was advisable, but according to the latest current consensus, a 30-degree tilt also has only 80% relieving the aortic cable compression. And the next thing which you can do is wedge under the right buttock. So once you know that a neuraxial blockade has been given and there is hypotension, there is definitely going to be some amount of aortic cable compression, which is inevitable. So it is very important to treat hypotension vigorously with vasopressors so that the blood flow to the fetus is not compromised. Now, what are the implications of these cardiovascular changes which I've been talking about? They usually, because the blood volume, as I said, it increases to about 94 ml per kg. So even when the patient loses around 1000 to 1500 ml of blood, they do compensate very well, and they do not have compensatory symptoms such as hypotension, which is occurring. So we tend to underestimate blood loss. That is number one. And in the presence of a resting tachycardia, and in a scenario where the baby is delivered, where you give syntocin, you give methergin. So your routine vital signs such as your heart rate and BP, they are all confounding factors and may not be reliable. So it's very important to visually estimate the blood loss in the immediate postpartum period and following delivery of the baby during LSCS section. The next thing which we have to observe is to communicate with the surgeon regarding the uterine tone. Because this will tell you, because whenever they start massaging, it is an indirect clue for you to know that, okay, the patient is losing something, and you get ready with your other venous access and colloids or blood in case if it is needed. So you don't wait for tachycardia and low BP to set in a case of an obstetric patient who's bleeding. And this is because hemorrhage can be very rapid and massive, as I already told you. The other cardiovascular complication that can occur is there is a risk for pulmonary edema when there is an inappropriate fluid administration. There is no requirement to preload these patients prior to giving a spinal blockade or anything. It is better we co-load them, that too not around 20 or 30 ml per kg. You give around a routine 3 ml per kg of crystalloid. You start your spinal anesthetic and you treat your hypotension with your vasopressors. And now the recommended vasopressor of choice is alpha agonist, namely the phenylephrine, depending on your heart rate and BP. These things will avoid pulmonary edema in the postpartum period. Then there should be, as I told you, vigorous treatment of hypotension with your vasopressors. When we look at the respiratory system changes, there is because of the estrogen and because of the increased total body water, there is engorgement of the respiratory mucosa. Not only the respiratory mucosa, all the mucosa are going to be enlarged, and there is hypervascularity of the submucosal spaces. And because of the increase in the mucosa and the vascularity, what happens to the airway spaces? They often get reduced. And in addition to that, when they are going into labor, what happens is every time they strain, there is a Valsalva maneuver, there is an upper airway edema that sets in. So a Malambati score, which was 2, could become 3 following prolonged induction of labor and when they're taking up for cesarean section. So we have to, every time when we see a patient, it's very important to assess Malambati score so that you be ready with your difficult airway management protocols. And when we look at respiratory mechanics, what happens to the well, let us go for systematically first from the skeletal system. What happens to the thoracic cage? When we look at the thoracic cage dimensions, there is an increase in the AP diameters and the transverse diameter. This enlargement occurs because the hormone relaxin, what happens is it relaxes your ligaments, your sternocostal ligaments. So the bucket handle movements are enhanced, and then it moves. One is there is elevation of your diaphragm from below, and the second thing is relaxin relaxes these ligaments, and so their AP and transverse diameter gets increased. But the vertical, this is a compensation for the decrease in vertical diameter of the thoracic cage that occurs following increase in the increased pushing of your diaphragm from below. So what happens to the type of respiration with these changes is predominantly it is a thoraco-abdominal type of breathing, and diaphragm is the main contributor of inspiration because the inspiratory muscles, your external intercostals and the other intercostals play a very minimal role because already they are in an expanded position because of the increase in the AP and the transverse diameter. When you look at the other mechanics in flow of airflow limitations and flow volume loops, they do not change much, and it is the same as pre-pregnant levels. The only change that occurs is with regard to your functional residual capacity, your residual volume, or your expiratory reserve volume, and your tidal volume. When you look at the overall total lung capacity, the total lung capacity remains the same. It is only the distribution of these volumes which gets altered, ultimately resulting in the increased incidence of hypoxemia. For example, as I told you, when there is an elevation, when there is a term gravid uterus, there is elevation of the diaphragm. This elevation of diaphragm causes decrease in functional residual capacity of about 20%. And when this patient goes to, this happens even in a sitting posture. Suppose the patient goes to lie down in the supine posture, there is further reduction in your FRC. So the functional residual capacity is the one which is going to be enormously decreased when the patient lies supine, especially more so when during neuraxial anesthesia and during transport of your patients. So though there is an increase in tidal volume by 45%, their functional residual capacity decreases by 25 to 30%. And as the functional residual capacity decreases, beyond your closing capacity is somewhere around 1000 ml. The closing capacity does not change. But because of your relationship between your functional residual capacity and your closing capacity, there is a stoppage of air exchange when the patient lies down in supine position, because during tidal breathing, there is airway closure. This is predominantly because of your FRC decrease, which occurs in the supine position. So they are prone for hypoxemia. It is very important to give supplemental oxygen whenever these patients are put in supine position during neuraxial anesthesia and during neuraxial anesthesia. When you look at the blood gas values, there is as I told you, there is an increase in minute ventilation. Increase in minute ventilation leads to decrease in your carbon dioxide levels. The primary reason for decrease in PCO2 levels is because of your increase in minute ventilation, which is mediated by your progesterone and by your which ultimately leads to increased alveolar ventilation. In order to compensate for this, there is a excretion of bicarbonate levels. So the bicarbonate levels is always in the range of 20 to 21 milliequivalents per liter in any pregnant patient. So when you look at an ABG which shows a PCO2 of 40 millimeters of mercury, then it denotes there is a hypercarbia which has set in this patient, and there is a respiratory failure, which they could be type 1 or type 2. All pregnant patients will have PCO2 only in the range of 30 to 32 millimeters of mercury. That is the carry home point. And when there is some insult to the metabolic component in terms of acidosis or low volume, they are unable to compensate this by their buffering capacity, because there is an inherent decrease in the level of bicarbonate which is there. So the buffering capacity, so whenever there is a small amount of acid load which has been given to this patient, their buffering capacity decreases. In addition to this, why are they more prone for hypoxemia? Because the oxygen consumption, when you see, it is around 4 ml per kg per minute, and with regard to the fetoplacental unit, it is 12 ml per kg per minute. So, though there is increase in tidal volume, minute ventilation, and your PaO2 is around 107 millimeters of mercury, whenever their tendency to desaturate is quite faster because the oxygen consumption is more. Number one, the consumption is more. Number two, they're at tidal breathing in the supine position, there can be airway closure. So the time to desaturate, when you look, is only 4 minutes, even after 99% denitrogenation of these patients. And during labor, the increase in minute ventilation, as I told you, is similar to cardiac output. This also increases by 142 to 200%. And because of this hyperventilation, the ODC curves, the dissociation curve shifts to the left, and there is a decreased unloading of the oxygen, which ultimately results in the fetal bradycardia or decreased oxygen delivery to the fetus. And also hypocarbia will also decrease your uteroplacental insufficiency. Going on to hematological changes, physiological hypervolemia we already dealt with. There is often anemia of pregnancy, which is present only in the first and the second trimester. And during the third trimester, the plasma volume increase is not much. So the hemoglobin concentration naturally increases more during the third trimester. And your total count is roughly about 6 to 16,000 cells per cubic millimeter, which should be the normal limit, unlike a pre-pregnant value of 6,000 to 9,000 levels. And when you look at the platelets, coagulation system, this is a phase where the platelet production is more, but at the same time, the platelet turnover is going to be high. There is accelerated consumption of platelets. The count might be low or normal, but the platelet function seems to be normal in most of these patients who do not have other coexisting diseases such as abruptio placentae or a severe ELP syndrome or a PIH. There is And when you look at the clotting factors, all the clotting factors are increased except your prothrombin and your factor V. The phenomenal increase in clotting factor which occurs is your fibrinogen levels, which increase to about 450 milligrams per deciliter. Because of this increase, when you do a routine conventional PT-APT test, they could be normal. Even after some amount of blood volume has lost, the coagulation factors are not very sensitive to the amount which is lost. So till only around 40% of the reduction occurs, these things will be showing a normal value because there is accelerated amount which is present. So it is very important you use dynamic test of coagulation to assess the quality of the strength in a bleeding patient rather than go for conventional test. Next thing to decrease is your decrease in your fibrin stabilizing factor. So there is an activated clotting time, but at the same time, the fibrinolysis is also more, and there is a decrease in fibrin stabilizing factor. So once the hemorrhage sets in, there is activated fibrinolysis. So this is the reason you have to give tranexamic acid in patients prior to as a first drug of choice in any patient with postpartum hemorrhage. And your target levels for fibrinogen should be, in a case of massive hemorrhage, it should be at around 200 to 250 milligrams per deciliter, unlike 150 milligrams in any other normal patient. When you look at obstetric physiology, as I've told you, it's a hypercoagulable state. Blood volume is increased. Stroke volume, heart rate, SVR, they are all decreased. So it improves the loss is rapid. The uterine flow is 700 ml per minute. It is 900 ml per minute. It is a source for rapid blood loss, and it can quickly become life-threatening. But when you look at the physiology, it is actually adapted and compensated for this blood loss. And so massive obstetric hemorrhage can occur without warning. And when you look at the neuraxial changes, there is an exaggerated lordosis. This exaggerated lordosis makes, what does that do? It often leads to technical difficulty in identifying your interspinous space because it gets narrow. The other thing which happens is because of your increased weight gain and an increase in plasma volume, there is some amount of edema. So technically palpation of your spaces becomes very difficult, and you have to angle, and there is softening of the ligaments. So identification of epidural space during by a loss of resistance technique is very tricky, because every segment as you advance, it will all be softening, and there can be increased incidence of intrathecal puncture. And when you give a spinal blockade in the lateral position, because of the widening of the pelvis, if you do not adjust the table, what happens is there will be more cephalite spread of the drug. And this is a study where they have done MRI of parturients, where the vertebral venous plexus were studied. What they found was there was, when you look at these white arrows, these are the vertebral venous plexus. When you look at these venous plexus, they are engorged veins in the ventral epidural space, and they are present bilaterally on both sides. And these veins, what do? Is they were compressing the subarachnoid space. This compression of the subarachnoid space was observed more at the lower levels of space, for example, L4 and L5, than at L1 and L2. And they often crossed at the middle of the vertebra, and the veins narrowed the foramens at each level. This engorged vertebral venous plexus is responsible to a certain extent for the decreased frequency. And in addition, because of the subarachnoid space getting compressed in the L4 and L5 space, when you give a spinal, the rate of paresthesia during spinal fracture is also quite high in pregnant women. And there is often a technical difficulty, which we have already told. There is softening of ligaments and increased incidence of vascular puncture, because one is engorgement, second, it is bilaterally present, and second, it is also present in the midline. And so every time you give an epidural dose for analgesia, it is very important you consider that as a test dose, like 0.0625% or a 0.125% should be given in incremental doses, because the migration of the catheter and blood staining is quite common in parturiting patients. And 25% dose reduction of local anesthetics is also essential. And when we look into the central nervous system changes, there is often a quite enormous amount of endorphins which are increased during pregnancy, and progesterone as such it is a central nervous system depressant. These two neurohormonal effects ultimately, what do they cause? They increase the pain sensitivity of pregnant mothers. The MAC of inhalational agents is quite decreased. So when you give a 0.6 or 0.6 MAC or 0.7 MAC, that is going to be when there is a 30% reduction, it is equivalent to 1 MAC, and there can be some amount of uterine tony or a upper airway obstruction which can occur when you're holding a mask. And also there is increased sensitivity to your intravenous induction agents. For example, when you give propofol, as it is your systemic vascular resistance is decreased, propofol further decreases it. So there is a increased incidence of hypotension during propofol induction, especially during induction of anesthesia. So all these things have to be kept in mind during induction of anesthesia, so that during induction, you avoid iodocaval compression, you give your phenylephrine, propofol, succinylcholine, and repeated monitoring of your blood pressures is very essential to avoid maternal collapse inside the OR. And when you look into the liver blood flow, apart from all the other organs, when you look at the flow in the liver, blood flow to the liver is decreased by 30%. But your portal venous pressure predominantly increases, which ultimately is a reason for spider nevi and telangiectasia, which you observe in some of these pregnant women. And important to us is your cholinesterase level and your albumin. So albumin levels decreases by around 25 to 30%, and it is around 3.2 grams per liter. And because of which the colloid oncotic pressure decreases to 18 millimeters of mercury. So these patients are more prone for pulmonary edema. One is there is an increased plasma volume. The hydrostatic pressure is more. Second is the colloid oncotic pressure is less. And there can be leaky capillaries in addition if they are having PIH and all those things. And in judicious administration of fluids along with syntocin can result in capillary escape and some amount of pulmonary edema. Though the cholinesterase level is reduced by 24%, we don't see a clinical increase in apnea time following administration of succinylcholine. And when you look at the GIT system, What are the things you have to? We all know that there is these patients are prone for gastric aspiration. The reason for gastric aspiration, when you analyze, is it the gastric volume, gastric emptying time, and the barrier pressure. These are the determinants ultimately, which will ultimately result in regurgitation and aspiration. So when you look at the gastric volume, the volume of acid that is secreted in response to gastrin is not altered during pregnancy, but during labor the volume can be more because of the pain and the sympathetic response. The next thing is your emptying time. Your emptying time also gets prolonged only during labor. Use of opioids, which can be intravenous opioids or neuraxial opioids, and stress, all these things can delay your gastric emptying time. And there is a pressure across the lower esophageal sphincter and the stomach, which is often called as the barrier pressure. This is the area where there is a high pressure zone, which is there in the lower end of the esophagus. This pressure is called as the barrier pressure. Routinely, this pressure is maintained because of the pinch valve mechanism of the intra-abdominal part of your esophagus. But during pregnancy, what happens is the stomach is pushed upward and there is alteration in your axis, so it gets rotated. Because of this, what happens is your abdominal part of your esophagus is pulled into your thorax. So the pinch valve mechanism is lost, which ultimately is responsible for your gastroesophageal reflex and silent regurgitation. So gastric motility is preserved. So alteration in your high pressure zone is responsible for your silent regurgitations, which can occur, and also progesterone is also responsible for relaxation of your lower esophageal sphincter tone. And when you look at the renal system, the serum blood flow, the renal plasma flow increases, your filtration rate is also more. So the response is your serum creatinine of 0.5 to 0.6 milligram per deciliter is normal. Any value more than this indicates that the patient has gone in for acute renal failure. And these patients have some amount of physiological glucose in their urine, and diabetes should be screened only based on your oral glucose tolerance test and not based on the urine sugar values. So what are the take-home messages? Cardiovascular changes are the predominant changes that occur in a pregnant patient in terms of heart rate, stroke volume, and cardiac output. The systemic vascular resistance decreases and your peripheral vascular resistance decreases. So any patient who's got a cardiac disease is going to decompensate during the course of pregnancy, and especially patients with stenotic lesions. Number two, if patients have got congenital acyanotic and cyanotic heart disease, where your systemic vascular resistance and your ratio between SVP and PVP ultimately decides your perfusion, that is also going to be altered. So it is a very dynamic situation. The incidence of difficult airway is very common in any pregnant patient for all the respiratory changes which I told you, and they are prone for pulmonary edema. Risk for bleeding and coagulopathy is rapid. They have increased sensitivity to anesthetic agents, and neuraxial analgesia and anesthesia is technically difficult, but it is the most advantageous and the ideal thing to do in any pregnant patient, even when they have cardiac disease, and avoid iodo-cable compression at all times. Thank you very much.
Thank you, madam, for excellent presentation. You have correlated the physiological changes with the clinical outcome also. Thank you, madam. There are a few questions. Can we go to the questions, madam?
Yes,
madam. So first question is, what symptoms and signs we have to look for peripartum cardiomyopathy during antenatal period?
Okay. So somebody who complains of dyspnea.
So disturbance in the audio.
So somebody who complains.
There is a disturbance in the audio, madam.
Dyspnea, okay, and fatigue. Can you hear me now? Is it audible?
Now we're audible. We can go.
Yeah. Okay. Any patient who is having new onset of dyspnea has to be evaluated. That is number one. And peripartum cardiomyopathy most often, most of our cases which we have seen in our institute, either it is a diagnosed one because they had a complaint of dyspnea or during routine echocardiographic evaluation. But sometimes what happens is they tolerate your labor pain very well, and when they come for PS, after giving a spinal anesthesia, we have had 2 to 3 cases of arrest. And most often when after that, when the screening echo was done, it showed an EF of 20%. So it's very difficult. You should have a high index of suspicion whenever the patient has got new onset of symptoms and when there is unrelenting hypotension following your routine neuraxial blockade, we can suspect. But actually, unless you screen all your pregnant patients with echocardiography, it is very difficult to identify just based on symptoms and signs alone. That's my experience, I would say.
Okay, madam. So the second question: how does the change in hormones affect the bone and joints, especially in the rheumatic arthritis?
Rheumatic
arthritis patients.
Rheumatic arthritis patients.
Yes. Usually there will be relaxation of the joint, that is the ligaments and joints. But what will happen in rheumatoid arthritis?
When you look at autoimmune diseases, all these autoimmune diseases, especially they will go in for a remission or there will be an exacerbation. So based on the symptom only we have to go ahead. There is no specific precautions which we have to take. I think the person wants to know whether we can give neuraxial anesthesia in a patient with rheumatoid arthritis or SLE or rheumatic. I think it is that. You are justified in giving these patients. Only thing is, if it is a severe involvement, what happens is it can be a difficult regional anesthesia, that we have to anticipate. And sometimes the blockade also might not be as expected. Sometimes it will be a very high anesthesia, very high levels of segmental blockade can be achieved because of the other alterations in the
Spinal canal.
Drug pharmacokinetics which can occur.
Okay, madam.
I think
yes. The third question.
I'm not sure whether I've answered
we don't know what is the mind of the questioner. It may be, I think it may be whether it is difficult to perform the neuraxial block in rheumatoid arthritis in pregnancy. I don't know. The third question is regarding the...
It depends on the course of the disease. For example, somebody who has a chronic rheumatoid arthritis with deformities in their small joints, then definitely it will be both a difficult airway and a difficult regional. Okay, so whenever you're dealing with rheumatoid arthritis patient, you have to be prepared for your difficult airway and choose a very small size tube because arytenoid dislocation is the most dreaded complication which you see in these patients. So we have to be aware of this. So just like that, even if you have a video laryngoscope, even if you have all the adjuncts, it should be a atraumatic intubation, and it is always advisable to use the size of the tube which is smaller, one size smaller. Even a 6 size tube would be sufficient in a patient with rheumatoid arthritis. And with regard to neuraxial anesthesia, yes, it is difficult. Ultimately, it is only the experience of the person who is doing it and the level of disease which ultimately decides the success, I would say.
Okay, madam. So we will move on to the next question. Regarding the supine hypertension syndrome of pregnancy, the 30-degree tilt, will it be convenient for the surgeon to perform the surgery? And another question is, will it cause a unilateral spinal anesthesia?
No. Very often pregnancy we are all safe because even with 1.8 ml, the moment you put your patients down to supine position, you will see the level of blockade achieving. That is the advantage we have. So there are no instances of unilateral spinal blockade in pregnancy, provided technically we have given it correctly. Okay, so there is if the spinal is not working in an LSES, it means it is to do with the performer rather than the drug or the patient, I would say. And the second thing is aortic cable compression. Yeah, some of the surgeons, they do agree for some of them. What we do is at the time of delivery of the baby, because unless they deliver the baby, we can't relieve the hypotension. So we just take out the wedge for that reason. Also, at that time we do take out. Okay, because it is all ultimately the surgeon has to deliver the baby, so we have to give them that edge.
Okay. So the dose reduction of neuraxial.
But most importantly, you have to treat hypotension vigorously. That is very important because now there is a debate going on whether you have to keep a wedge in all patients. If you're maintaining your hemodynamics, it is not necessary to keep a wedge in lateral tilt and all these things. So the most important thing is treat your hypotension vigorously. That is the most important, so that your blood flow is maintained. And ultimately, the surgeon also will be very fast in delivering the baby if you're not compromising on the tilt.
Yes. The recent concept is if the patient is normovolemic, you need not keep that.
Normovolemic and low risk patient, you do not keep.
Thank you, madam. The dose reduction of neuraxial anesthesia of 25%, when we have to start, madam? From which?
This one, this 25% dose reduction, it starts as early as around 18 to 20 weeks of pregnancy. For example, someone is coming for an open appendicectomy or a cervical encephaloplasty. Sometimes even during that time, this dose reduction is advisable. But this dose reduction, what happens is the sensitivity comes down when the patient comes for P. It's actually 24 to 40. This dose reduction is applicable only till 48 hours postpartum. After that, what happens is you have to give a regular volume of drug for your puerperal sterilization.
Okay. Thank you, madam. Thank you very much for your excellent explanations. And we will move on to the second topic. That is. The second topic is Anesthetic Management of Non-Obstetric Surgeries in Pregnant Patients by Dr. VINEET GUPTA. He is a consultant anesthesiologist affiliated to Cloudnine Hospital, Apollo Cradle Hospital, and Daffodil Artemis Hospital. He has worked in India and abroad as clinicians in dealing with cases of obstetrics, bariatric, plastic, and reconstructive operative procedures. His major area of interest is labor and general anesthesia in obstetric anesthesia. The anesthetic technique is almost forgot by our postgraduate, that is general anesthesia in obstetric anesthesia. He is expert in that, and he has written articles in the various topics of anesthesia for students by the name of Quick Dose. He is at present the secretary of ISA City branch of Gurugram, and he is present vice president of the most prestigious TAS society, that is the Anesthetic Society. Over to you, sir.
Good morning, friends. Thank you very much, Dr. Edward, for giving my introduction. I'm humbled by your way of introducing me to the platform. Thank you very much, Akila ma'am. It was a very, very nice presentation, and it reminded me of my student days. Physiology should be treated and taught like this. Thank you very much, Dr. Akila. So here I will be starting my screen share, and I'll start my presentation.
Okay, you can share.
Can everybody see my presentation now?
Yes, it's visible, sir.
Okay. So the topic given to me today is anesthetic management of non-obstetric surgery in pregnant patients. You see, this topic is usually bring down shivers into the slide is not moving. Hello.
Slide is not moving, sir.
Trying to move my slide.
Yes, now it's moving, sir.
Okay.
Moving, sir.
So it brings down shiver to your spine once you know that there is a patient coming for acute appendicitis, and she is being posted for laparoscopic appendicectomy, and she is 3 months pregnant or 6 months pregnant or whatever it is, term pregnant or early pregnancy, whatever it is. So the thing is, you must know few things to tell patient and to counsel patient about all these things, because stress management, your as a clinician as well as of the patient, is very, very important for this kind of surgeries in pregnancy. So frequency is usually 0.3 to 2.2%. It's varied from place to place, and 2% to somewhere it is written 2.2% to 3%. But usually it is, if we take roughly, it is 2%. So in 2010, UK National Patient Safety Agency said that women should be offered a pregnancy test if there is any possibility that the woman could be pregnant. If she is coming for a surgical indication, she should be offered a pregnancy test. The other good recommendation was American Society of Anesthesiologists Task Force on pre-anesthesia evaluation stats that This is actually taking offload from the treating doctors or treating anesthesiologists, that literature is inadequate to inform patient or physician on whether anesthesia causes harmful effect in early pregnancy. See what happened once this kind of patient is there with us, and if surgeon calls us or if 14 manager calls us, we take every load on us. We start thinking of like we are putting patient on danger. No, it's not like that. We are actually helping the patient in crucial time. So start thinking positively that we are not going to harm the patient. Our technique, our anesthesia drugs are as safe as others. And we are the safest mode of providing medical treatment during the surgery. And whatever drugs we are going to use, whatever techniques we are going to use are very, very safe. So this will actually offload you from the stress you are going through. And once you are offload from the stress, once you are going to talk to that patient, the patient will be very comfortable, they will be stress-free. And stress and anxiety has a very big role on these kind of patients. Once you are convinced, you will convince your patient. Once your patient is convinced, your half job is done. So the surgeries commonly performed during pregnancy are directly related with pregnancy, like cervical surglus, and then indirectly related with pregnancy, like ovarian cystectomy, unrelated to pregnancy, like appendectomy, trauma, or acute abdominal. Possible risk to the fetus of antenatal surgeries. The effect of the disease process itself or related therapy. Then the teratogenicity of the anesthetic agent or any other drug administered during the perioperative period. So this is a very subtopic of this topic, teratogenicity of the anesthetic agent. We will be talking at little length on this topic. Then intraoperative changes of uteroplacental perfusion and or fetal oxygenation. Most of it has been, discussed, Dr. Akilandeswari, but we will still revise it during our presentation. Then the risk of abortion or preterm delivery. The outline of today's class is first, the maternal safety, altered maternal physiology. Second is fetal consideration, and third is the practical considerations. Maternal safety or altered maternal physiology, as ma'am already discussed, there are 5 main systems which are affected physiologically. One is the respiratory system acid-base balance. Second is cardiovascular. Third is blood volume and blood constituents. Fourth is GI, and fifth is altered response to anesthesia. So we will take in broad lines. Alveolar ventilation increased by 30% and PSO2 runs between 28 to 32%, slightly alkaline 7.44. Consumption increased by a little bit, slightly remains within the normal range. Functional residual capacity diminishes by approximately 20% as the uterus expands, resulting in decreased oxygen reserve and potential for airway closure. This all is already discussed very nicely in madam's topics. When FRC is decreased further from morbid obesity, perioperative intra-abdominal distension, placement of uterus in the patient in the supine, tender limbic position or lithotomy position, or induction of anesthesia, airway closure may be sufficient to cause hypoxia. That is the important point. Respiratory system, weight gain during pregnancy, capillary engorgement, respiratory tract mucosa engorgement, and difficult intubation. Failed intubations are more frequent during pregnancy. Decreased FRC, increased oxygen consumption, and diminished buffering capacity result in rapid development of hypoxemia and acidosis during period of hypoventilation or apnea. Failed intubation is very important point, or difficult intubation is very important point while we are dealing with these kind of patient under general anesthesia. My personal experience is try your best. Like if you are tentative, you have done conventional laryngoscopy, and you see only a lower half or lower 1/3 of the larynx visible to you. You think that you may or may not be able to negotiate the tube in the first instance. It's better to start with bougie, because there is no point trying once, traumatizing the mucosa, and then trying with the second chance with this bougie or stellate. It's better to start with the bougie and go in one go, because intubation done in first go or one go is the best policy in pregnant patient. Never try. Use the best experienced hand for the intubation. You can teach your students anywhere on any patients. You can teach them through the video laryngoscope. Even if you are teaching your resident, use the third-year resident at least to intubate the patient. Nothing personal, nothing offensive to the junior students. They will also do it once the time will come. Induction of inhalational anesthesia occurs more rapidly during pregnancy because alveolar hyperventilation and decreased FRC allow faster equilibrium of inhaled agent. Induction of anesthesia is accelerated owing to 30 to 40% decrease in the minimum alveolar concentration for volatile anesthetic agent that occurs during early pregnancy. Cardiovascular changes, 50% cardiac output increases because of heart rate and stroke volume. We know the systemic pulmonary vascular resistance decreases. Important point is by 24-week gestation, most of the physiological changes of cardiovascular system has happened. But out of these 24 weeks, first 8 weeks are very important because 57% of the increase in cardiac output, 78% of the increase in stroke volume, and 90% of the decrease in systemic vascular resistance is already happened in first 8 weeks of gestation. So first trimester of the pregnancy is very much important regarding the physiological changes of pregnancy. During the second half of the gestation, the uterus compresses the inferior vena cava and venous return decrease by 30%. In some women, frank hypotension may occur in supine position. Vena cava compression, as we know, will cause distension of epidural venous plexus. It increases the likelihood of intravascular injection, local anesthetic during epidural anesthesia. We have to be very careful and sophisticated and gentle in our regional anesthesia techniques in these kind of patients. Changes in blood volume and blood constituents. Blood volume expand in the first trimester and increase 30 to 45% by time. Dilutional anemia occur as a result of smaller increase in red blood cell volume and then in plasma volume. Pregnancy is associated with benign leukocytosis. In general, pregnancy has a hypercoagulable state with increase in the fibrinogen factor 7, 8, 10th, and 12th, and fibrinogen degradation product. Although there is thrombocytopenia, but in some pregnant women, these patients may still be hypercoagulated. During the postoperative period, pregnant surgical patients are at high risk of thromboembolic complications. Thus, thromboembolism prophylaxis is recommended. GI system, incompetence of the lower esophageal sphincter and distortion of gastric and pyloric anatomy during pregnancy increases the risk of GI reflux, despite similar gastric emptying rates in the pregnant and non-pregnant patient. Although lower esophageal sphincter tone is impaired early in pregnancy, the mechanically induced factors do not become relevant until later in the pregnancy. It's prudent to consider any pregnant patient as having a higher risk for aspiration after mid-gestation. This is my personal experience that one patient given a history of empty stomach for 12 hours and she vomited like anything. So my humble request or teaching to everyone is always consider a pregnant patient full stomach. Some anesthesia providers believe the pregnant women are at increase of risk of aspiration from the beginning of the second trimester onwards. Then alternate response to anesthesia, MAC decrease, more extensive neural blockage attained with the epidural and spinal anesthesia in pregnant patient because of the engorgement of the space. Plasma cholinesterase level decreases by 25% from the early pregnancy to the 7th postoperative day. Fortunately, prolonged neuromuscular blockage with succinylcholine is uncommon. Decreased protein binding associated with lower albumin and alpha glycoprotein concentration during the pregnancy may result in larger fraction of unbound drug with a potential for greater drug toxicity during pregnancy. Then pregnancy-associated changes in volume of distribution due to change in body composition and or plasma protein binding capacity, metabolic activity, and hepatic or renal impairment, elimination may contribute to the change in drug effects and metabolism. Then this is the physiological part. The next part is fetal concentration. So actually our today's lecture is starting from there. It is divided into three main parts: risk of teratogenicity, fetal effect of anesthesia, and prevention of latent labor. So first we will deal with this risk of teratogenicity. Most teratologists accept that the principle that any agent can be teratogenic in an animal provided that enough is given at right time. That means a small dose of teratogen may cause malformation or death in the susceptible early embryo, whereas much larger doses may prove harmless to the fetus. It is the time of organogenesis. Early first trimester pregnancy is the time of organogenesis, and it is the time or stage where it is very common for any drugs to be acting as a teratogen. Risk of teratogenicity, you can see the increasing dose mode factors to teratogenic zone, to embryo lethal zone, to maternal lethal zone. So you can see teratogenic zone is ending while embryo lethal zone is full-fledged. It is because when embryo is died, nobody is going to see the teratogenicity of the died embryo actually. So and it cannot be manifested once the baby is not delivered. So teratogenicity is studied only in the embryos who are born live or evaluated well. Then once the doses crosses embryo lethal zone and embryo is also died, then it start affecting even the maternal population. Risk of teratogenicity, manifestation of teratogenicity include death, structural abnormality, growth restriction, and functional deficiency. Death is referred to as abortion, fetal death, or stillbirth in human, and as a fetal resorption in animals. Structural abnormalities can lead to death if they are severe, although death may occur in the absence of congenital anomalies. Growth restriction is considered a manifestation of teratogenesis and may relate to multiple factors, including placental insufficiency and genetic and environmental factors. Then functional deficiency include a number of behavioral and learning abnormality, the study of which is called behavioral teratology. Then risk of teratogenicity. This picture is very good depiction of teratogenicity. You can see first 2 weeks, they are period of dividing zygote, implantation and bilaminar embryo. No susceptible to teratogenicity because they will die then and there. Then from 3rd to 8th of week, we can see central nervous system and heart. In 3rd week, 4th week, eye, heart, and limbs. And then 5th week, eye, 6th, teeth and ear, then palate, then ear. We can see the dark bars and then followed by the light bars in the same area. The dark bar is higher susceptibility and the light bars are actually the lowering susceptibility. But important point is brain. You can see the brain, even it is affecting once the patient, the fetus is full term. So we have to be very careful about all those things. Most structural abnormalities result from exposure during the period of organogenesis, which extends from approximately day 31 to 37. That means almost 10 weeks, 9-10 weeks. That is the most susceptible period for teratogenicity. Functional deficiencies are usually associated with exposure during the late pregnancy or even after birth, because the central nervous system continues to mature during this period. Then the incidence of congenital anomalies among humans is approximately 3%, most of which are unexplained. And out of that, only 2 to 3% with the drugs and environmental chemicals. Indeed, Shepard has listed several criteria for determining that an agent is a human teratogen, including the following. Only these criteria will tell us that the particular drug is teratogen or not. 1, proven exposure to the agent at the critical time of development. 2, consistent finding in 2 or more high-quality epidemiological studies. 3, careful delineation of the clinical cases, ideally with the identification of a specific defect or syndrome and an association that makes biological sense. The list of agents or factors that are proven human teratogen does not include anesthetic agents. So are you happy now? Which are listed as unlikely teratogen or any drug routinely used during the course of anesthesia. So this is the point I was giving my importance, that why it is important for you or for us to be stress-free while dealing with these patients. And once you know that none of your drug is actually teratogen, you will be feeling comfortable, you will be convincing with your drugs, your process, your machinery, and then you will convince your patient that, madam, don't worry. We are using with very safe drugs and it's not going to affect you adversely. Non-drug factor encountered in the perioperative period, derangement of normal physiology, hypoxia, hypercapnia, stress and abnormality of temperature and carbohydrate metabolism. Congenital anomalies, especially involving the CNS, have repeatedly been associated with maternal fever. Temperature is very important. Usually the temperature of fetus is 0.5 to 1 degree centigrade, higher than the maternal temperature. And once mother have a fever, membranic oxidative stress from the reactive oxygen species has been implicated as one of the mechanisms involved in the teratogenicity of many agents. Second, the chronic hypoxemia experienced by mother at high altitude result in the delivery of infants with lower birth weight, but with no increase in the rate of congenital defects. It will only affect the birth weight. Then maternal stress and anxiety are teratogenic in animal, but their significance as human teratogens remains questionable. Severe hyperglycemia and prolonged hypoxia and hypercarbia have caused congenital anomalies in laboratory animals, but there is no evidence to support teratogenicity after brief episodes in humans. So brief episodes is not going to harm as we think they will be. Then diagnostic procedure, ionized radiation is a human teratogen that can result in an increased dose-related risk for malignant disease, genetic disease, congenital anomalies, or fetal death. The effect of radiation are often classified as being deterministic and stochastic. Deterministic effects are dose-related and observed above a certain threshold dose: pregnancy loss, growth restriction, mental retardation, or organ malformation. In contrast, stochastic effects are possible at any level of exposure with no minimum threshold, but with the likelihood of worsening effect at higher doses. Radiation is expressed as gray or milligrays. 1 gray is equal to 100 rad and is evaluated as cumulative dose, that is background radiation and medical diagnostic radiation throughout the entire pregnancy. In contrast to the negligible risk of teratogenicity, observational studies suggest that there is a slightly higher risk for childhood cancer at radiation doses greater than or equal to 10 milligray. So 10 milligray is very important figure. I will show you a few of the charts or commonly done exposures during pregnancy, possible pregnancy and possible exposure, and how it is relevant 10 milligray. You see the first table, and you can see the first line is of minimum exposure and the second line is of maximum exposure. So it says the 10 milligray exposure is crossed only by intravenous urogram, lumbar spine X-ray. Then fluoroscopic examination, it is the barium enema, not barium meal, because it is upper GI. Then computer tomography, almost all abdominal, and then pelvic CT scans. Then estimated fetal radiation exposure for common interventional radiological procedures. It is ERCP, it can reach to 55.9 milligrays, and then 42 uterine fibroid embolization. So here we have to be very careful while we are doing uterine fibroid embolization. 42 milligrays is the minimum estimated exposure. So we have to be very careful and judicial about choosing this procedure. The non-drug factors encountered in the perioperative period in intravenous iodinated contrast media. It can cross the placenta, go to the fetus, can cause hypothyroidism in the fetus. Then diagnostic ultrasonography, usually considered very safe, and intensities up to 20 watt per centimeter have been found to be safe. However, when higher intensities, more than 30 watt per centimeter have been used, or when repeated exposure have been occurred during early pregnancy, postnatal neurobehavioral effect have been described. Again, neurobehavioral effect is directly related with the temperature. Ultrasound actually increases the temperature or hypothermia, and that will affect actually the neurobehavioral changes in fetal brain. So Doppler interrogation emits significantly more acoustic intensity than pulse echo imaging equipment, thus more heat is generated. Therefore, Doppler technology should be used judiciously, keeping the exposure time and acoustic output to the lowest level possible. However, gadolinium-based MRI contrast agent readily crossed the placenta. No adverse effect on pregnancy and neonatal outcome was noted in a small series of patients. The American College of Radiology recommends that intravenous gadolinium be avoided during pregnancy and used only if absolutely essential. Then commonly used anesthetic agents, systemic agents, human studies. I will only be talking about human studies, these kind of agents. Teratogenesis has not been associated with the use of any of the commonly used induction agent, including barbiturates, ketamine, and benzodiazepines. When they were administered in local clinical doses during anesthesia, similarly, no evidence support the teratogenicity of opioids in humans. There is no increase in the incidence of congenital anomalies among offsprings of mother who use morphine or methadone during pregnancy. No evidence suggests that a single dose of benzodiazepines, midazolam, during the course of anesthesia is harmful to the fetus. Local anesthetic, no evidence support teratogenicity associated with any local anesthetic used clinically in humans. Maternal cocaine abuse is associated with adverse reproductive outcome, including abnormal neonatal behavior, and in some reports, a higher incidence of congenital defects of the genitourinary and GI tracts. The greatest risk to the fetus most likely results from the high incidence of placental abruption associated with maternal cocaine use. Commonly used anesthetic agents, muscle relaxants. Given the fetal blood concentration of muscle relaxants are only 10 to 20% of maternal concentration, these drugs appear to have a wide margin of safety when administered to the mother during organogenesis. Many women have received muscle relaxant for several days during late gestation without adverse effect on the neonate. One case report described arthrogryposis, that is persistent joint flexure in the infant of a woman with tetanus who received D-tuberculare for 19 days beginning at 55 days of gestation. The patient also was hypoxic and received multiple other deaths. So the contributory factors were also there. Then inhalational anesthetics, occupational exposure to waste anesthetic agent. The most consistent risk associated with occupational exposure was spontaneous abortion, which carried a relative risk ratio of 1.3. Shirangi et al. Proved that prevalence of preterm birth in women exposed to unscavenged anesthetic gases was 7.3% compared with 5.7% in general population. Other studies have not confirmed an association between operation room work and higher reproductive risk. Similarly, in a 10-year prospective survey of all female physicians in the United Kingdom, found no difference in reproductive outcome when anesthesiologists were compared with other working female physicians who have not exposed to unscavenged anesthetic gases. Overall, the epidemiological data do not support an increased risk for congenital anomalies with long-term exposure to nitrous oxide. Then studies of operation performed during pregnancy. Although anesthesia and surgery are associated with high incidence of abortion, fetal growth restriction, and perinatal mortality, these adverse outcomes can often be attributed to the procedure, the site of the surgery, and or the underlying maternal condition. So, We need not to blame or to doubt always on ourselves, our technique, our medicines. There are some contributory factors, and there are some uncleared actual etiology related with all these adverse outcomes. Evidence does not suggest that anesthesia during pregnancy results in an overall increase in congenital abnormalities, and there is no evidence of relationship between outcome and type of anesthesia. Then behavioral teratology currently used general anesthetic agents acts by one of the two principal mechanisms. One, the potentiation of GABA-A receptor, that is benzodiazepines, volatile hallucinated agent, and barbiturate, and two, the antagonism of NMDA receptors, nitrous oxide and ketamine. CNS may be specifically sensitive to such influences during the period of major myelination, which in human extends from 4th intrauterine month to the 2nd postnatal month. So again, emphasis is on the 2nd postnatal month, CNS. CNS is very, very important because that is the only system which in fact being affected even postnatally. After a review of the data, a public hearing in March 2007, the Anesthetic and Life Support Drugs Advisory Committee of the US Food and Drug Administration stated that currently there are not adequate data to extrapolate the animal findings to humans. It is also important to remember that painful stimuli per se can cause long-term behavioral changes. Then fetal effect of anesthesia. Maternal and fetal oxygenation. Transient mild to moderate decrease in maternal PO2 are well tolerated by the fetus because fetal hemoglobin has a high affinity for oxygen, one. Second, severe maternal hypoxia may result in fetal hypoxia and if persistent may cause fetal death. Second is actually oxygen dissociation curve. Fetal PO2 never exceeds 60 millimeter of Hg even when maternal PaO2 increases to 600 mm of Hg because of large maternal fetal oxygen tension gradient. Thus, intrauterine retrolental fibroplasia and premature closure of ductal arteriosus cannot result from high level of maternal PaO2. Maternal carbon dioxide and acid-base status. Maternal hypercapnia can cause fetal acidosis because fetal PaCO2 correlate directly with the maternal PaCO2. Although mild fetal respiratory acidosis is of little consequences, severe acidosis can cause fetal myocardial depression and hypotension. Maternal hyperventilation with low maternal PaCO2 and high pH can adversely affect fetal oxygenation by means of several mechanisms. Respiratory or metabolic alkalosis can compromise maternal fetal oxygen transfer by causing umbilical artery constriction and by shifting the maternal oxygen hemoglobin dissociation curve to the left. Thus, hyperventilation should be avoided in the pregnant surgical patient rather than PaCO2 should be kept in the normal range for pregnancy. Maternal hypotension from any cause can jeopardize uteroplacental perfusion and cause fetal hypoxia. The most common cause of hypotension in the pregnant patient undergoing surgery include deep level of general anesthesia, sympathectomy with high level of spinal or epidural blockage, aortocaval compression, hemorrhage, and hypoxia. A meta-analysis of randomized controlled trial comparing ephedrine and with phenylephrine for the treatment of hypotension during spinal anesthesia for cesarean delivery resulted in the following conclusion. There was no difference between phenylephrine and ephedrine for the prevention and treatment of maternal hypotension. That means they are equally effective treating maternal hypotension. Maternal bradycardia was more likely to occur with phenylephrine. Actually, they wanted to say that tachycardia is less with phenylephrine. Women given by phenylephrine had neonates with higher umbilical arterial blood pH measurement, which seems to be a little bit favorable to the fetus. There was no difference between two vasopressors in the incidence of two fetal acidosis. Umbilical artery pH less than 7.2 is, both of them are not cannot be blamed for pH less than 7.2. Supporting the hypothesis that the lower fetal pH observed with ephedrine is related to the metabolic effect secondary to stimulation of fetal beta adrenergic receptor, The use of phenylephrine to treat maternal hypotension is acceptable and may be preferable to epidural. Fetal and neonatal outcome were unaffected when maternal systolic blood pressure was kept between 70 to 80 millimeter Hg, even when pressure as low as 50 millimeter Hg were briefly permitted. Preoperative anxiety and light anesthesia increases circulating catecholamine level and possibly impairing uterine blood flow. So here it comes the my point. I started my discussion. Preoperative anxiety, that is very important. So if you deal with the preoperative anxiety while counseling the patient, the outcome will always be very good. Relevance of data to the human mother undergoing surgery during pregnancy is not clear. Clinical experience does not support avoidance of volatile agents provided that the maternal hypotension is prevented. Indeed, the depressant effect of these agents on myocardial contractility may be beneficial. If intraoperative fetal heart rate monitoring reveals signs of fetal compromise, it may be advisable to discontinue volatile agents until the fetal condition improves. Then fetal effect of systemic drug, opioids and induction agent decreases FHR variability. This finding most likely signals the presence of anesthetized fetus and is not a cause of concern in the absence of maternal hypotension. Fetal heart rate variability, if it is decreasing with the opioid and induction agent, it does not matter if the patient's maternal blood pressure is normal. Fetal respiratory depression is relevant only if cesarean delivery is to be performed at the same time as the surgical procedure. Otherwise, how does it matter if a first trimester pregnancy is being treated for appendectomy and we are afraid of giving fentanyl or opioid because we think that the fetal respiration will be depressed? So what? Fetus is not going to breathe inside the mother womb. So how does it matter? Maternal administration of muscle relaxant and reversal agent typically has not proved to be problematic for the fetus. Slow administration of anticholinesterase is recommended, that too even after prior injection of an anticholinergic agent. Because the effect of reversal agents are unpredictable, the monitoring of FHR during maternal drug administration is suggested. Then comes the third point, prevention of preterm labor. Although the volatile agent depresses myocardial irritability and thus are theoretically advantageous for the abdominal procedure, evidence does not show that any one anesthetic agent or technique positively or negatively influences the risk of preterm labor. So need not to worry about choosing your anesthetic agent or technique. Monitoring for uterine contraction may be performed intraoperatively with an external tocodynamometer when it is technically feasible. But be careful while applying it first time, and if it is hampering the surgical procedure and if it will be delaying the surgery, overall benefits actually is not much than the time taken. It's better to finish the surgery in 20 minutes than applying tocodynamometer for 20 minutes and delaying the surgery for 2 hours. A relatively new class of tocolytic agents, oxytocin receptor antagonists, that is atosiban, has been investigated. Atosiban selectively blunts the calcium influx in the myometrium and thus inhibits the myometrial contractility. More or less, it will be working as nifedipine. Then magnesium sulfate is among the most common drug used in the pregnancy as a tocolytic, anticonvulsant, or fetal neuroprotective agent. Then comes the third most important part of this topic, that is practical consideration, timing of the surgery. Elective surgery should not be performed during the pregnancy. When possible, surgery should be avoided during the first trimester, especially during the period of organogenesis. Second trimester is the optimal time to perform surgery because the risk for preterm labor is lowest at that time. The management and timing of most acute surgical procedures should mimic that for the non-pregnant portion. If the condition is acute, if it is an emergency, forget the patient is pregnant. Appendiceal perforation may be more common in pregnant patient than in non-pregnant patient. Generalized peritonitis may also be more likely because increased steroid levels during pregnancy. Forget the patient is pregnant does not mean that you forget the patient is pregnant. While you are taking a decision about the surgery, that time you can keep that point that patient is pregnant or non-pregnant aside. and take the decision as if they're taking a decision for the non-pregnant patient. In the event of serious maternal illness, the remote fetal risk associated with anesthesia and surgery are of secondary importance. The primary goal is to preserve the life of the mother. You save the tree, you will get more fruits. Hypothermia-induced hypotension, cardiopulmonary bypass, and liver transplantation have been associated with successful neonatal outcome. What all surgical condition can put you on these kind of patient on surgical table? Or some of them are gynecological problem, other are non-gynecological problem. Gynecological problem like ovarian cyst, tumor, rupture, torsion, hemorrhage, infection, torsion of fallopian tube, tubo-ovarian mass, uterine myomas, degenerated, infected, and torsion. The non-gynecological problem are acute appendicitis, acute cholecystitis and its complications, acute pancreatitis and its complication, intestinal obstruction, trauma with visceral injury or hemorrhage, vascular accident, ruptured abdominal aneurysm, or peptic ulcer. Abdominal emergencies. Problem is abdominal emergencies are pregnancy mimicked with the sign of acute abdomen, like nausea, vomiting, constipation, and abdominal distensions are common symptoms of both normal pregnancy and abdominal pathology. Then abdominal tenderness may be indistinguishable from ligamentous or uterine contraction pain. The white blood cell count in normal pregnancy may reach up to 15,000 to 16,000 per cubic millimeter. It must be mildly elevated to be diagnostically helpful. So again, the diagnosis is hidden behind the raised normal count. Then reluctance to perform necessary imaging studies involving radiation. Everyone is afraid of doing radiation, X-ray or ultrasound or doing CT scan in these kind of patients. Sometimes the correct diagnosis is determined only at the time of operation. Then laparoscopy. Concern exists about the effect of laparoscopy on fetal well-being, especially the risk are uterine or fetal trauma, fetal acidosis from absorbed carbon dioxide, decreased maternal cardiac output, and uteroplacental perfusion resulting from an iatrogenic increase in abdominal pressure. But the benefits are shorter hospitalization, less postoperative pain, decreased risk for thromboembolic and wound complications, and faster return to normal activities, including early return of normal GI function, less uterine irritability, and less fetal depression. General anesthesia has been used in the vast majority of laparoscopic procedure with a rapid sequence induction followed by tracheal intubation and positive pressure ventilation to maintain end-tidal CO2 between 32 and 36. Slightly higher, normal to CO2 level are, it's better to keep them slightly to the higher side or to the normocapnia side. Because hyperventilation accumulated, we want to flush out of accumulated CO2, we do hyperventilate and we forget that PCO2 has came down to 25 or 26. At that time, there will be severe fetal vascular perfusion compromise. As with open surgery, fetal well-being is best preserved by maintaining maternal oxygenation, acid-base status, and hemodynamic parameter within normal pregnancy limits. The FHR and uterine tone should be monitored both before and after the surgery. So there is a suggested guideline for laparoscopy during pregnancy, indications for laparoscopy treatment. Then laparoscopy can be safely performed. Preoperative obstetric consultation should be obtained. Intermittent lower extremity pneumatic compression device should be used. Fetal heart rate and uterine tone should be monitored. End-tidal CO2 should be monitored. Left uterine displacement should be maintained to avoid aortocaval compression. But to my experience, it's better to give surgeon a little liberal hand while giving the position of the patient, because once we give them liberty, they finish up very quickly and ultimately the results are good. An open technique, a vessel needle, varices needle, or an optic trocar technique may be used to enter the abdomen. Low pneumoperitoneum pressures between 10 to 15 millimeter wedge. Anyway, we are keeping this much of pressure. Tocolytic agents should not be used prophylactically, but should be considered when evidence of preterm labor is present. Then anesthetic management, preoperative management, medication may be necessary to allay maternal anxiety. Actually, if you convince and you talk to patient, good 5-10 minutes, you need not to give any sedative or anti-anxiety drug or midazolam, something like that. Pregnant women are at increased risk for acid aspiration after 18 to 20 weeks of gestation. Pharmacological precaution against acid aspiration may include pre-anesthetic administration of histamine receptor antagonist, metoclopramide 10 mg IV, and a clear non-particulate antacid such as sodium citrate. Then choice of anesthesia, maternal indication, and consideration of the site and nature of the surgery should guide the choice of anesthesia. No study has found an association between improved fetal outcome with any specific anesthetic technique. When possible, however, local or regional anesthesia because it permits the administration of drug with no laboratory or clinical evidence of teratogenesis. These techniques are suitable for cervical circulars and urological or extremity procedures. Most abdominal operations require general anesthesia because the incision typically extends to the upper abdomen. Then prevention of aortic cable compression. Beginning at 18 to 20-week gestation, the pregnant patient should be transported on her side and the uterus should be displaced leftward when she is positioned on the operation table. Then monitoring. Usually, maternal monitoring should include non-invasive or invasive BP, ECG, pulse oximetry, technography, temperature monitoring, and use of peripheral nerve stimulator. The fetal heart rate and uterine activity should be monitored both before and after the surgery. Intraoperative FHR monitoring may be considered when technically feasible. Then anesthetic technique, general anesthesia mandates tracheal intubation at onwards 18 to 20 week gestation, or even if it is less than 18 to 20 weeks, if the stomach is full. The point is, we can get away with the supraglottic device in many of these general anesthesia non-pregnant patients, but be careful while using the supraglottic airways during early pregnancy. Denitrogenation should be precede the induction of anesthesia, rapid sequence induction. Drugs with a history of safe use during pregnancy include most of the commonly used agents like thiopentone, propofol, morphine, fentanyl, succinylcholine, and almost all non-depolarizing muscle relaxants. A commonly used technique employs a high concentration of oxygen, a muscle relaxant, and an opioid and/or nitrous oxide, particularly after the 6th week of gestation. After 6 weeks of gestation is mainly emphasized for nitrous oxide and moderate concentration of volatile hallucinogens. A conscious approach would restrict nitrous oxide administration to a concentration of 50% or less and would limit its use in extremely long operations. Hyperventilation should be avoided, rather end-tidal CO2 should be maintained in the normal range for pregnancy. Rapid intravenous infusion of 500 ml of crystalloid immediately before or during the initiation of spinal or epidural anesthesia seems prudent. Vasopressor should be available to treat hypotension if it occurs. Maternal hypotension should be treated aggressively. Regardless of the anesthetic techniques, steps to avoid hypoxemia, hypotension, acidosis, and hyperventilation are the most critical element of the anesthetic management. Then post-operative management, the fetal heart rate and uterine activity should be monitored during recovery for anesthesia. Adequate analgesia should be ensured with systemic and neuraxial opioids, acetaminophen, and neural blockade. Prophylaxis against venous thrombosis should be considered, especially if the patients are immobilized. Take-home message are a significant number of women undergo anesthesia and surgery during pregnancy for procedure unrelated to delivery. Maternal risks are associated with anatomic and physiological changes of pregnancy, that is difficult intubation or aspiration, and with the underlying maternal disease. The diagnosis of abdominal condition may be delayed during pregnancy, increasing the risk for maternal and fetal morbidity. Maternal catastrophe involving severe hypoxia, hypotension, acidosis poses the greatest acute risk to the fetus. Other fetal risks associated with surgery include fetal loss, preterm labor, growth restriction, and low birth weight. clinical studies suggest that anesthesia and surgery during pregnancy do not increase the risk of congenital anomalies. The point here is the brief period of exposure actually. So we should not blame the surgery and anesthesia per se for any kind of congenital anomalies if it is found later on after the delivery of the baby. It is unclear whether adverse fetal outcome result from the anesthetic, the operation, or the underlying maternal disease. No anesthetic agent is a proven teratogen in human, although some anesthetic agents, specifically nitrous oxide, are teratogenic in animals under certain conditions. Many anesthetic agents have been used for anesthesia during pregnancy with no demonstrable difference in maternal or fetal outcome. The anesthetic management of a pregnant surgical patient should focus on the avoidance of, again, hypoxia, hypotension, acidosis, and hyperventilation. Thanks to my guru, my book. I am not a regular teacher in a medical college. I'm not a professor, so I do not share. I do not have a chance to share the knowledge, to get the knowledge from the college students, from the fellow teachers. I have my guru, Chestnut Obstetric Anesthesia book, which I religiously follow for my obstetric anesthesia practice. Thank you very much for giving me an opportunity to speak about this topic.
Thank you, sir. You elaborately covered all the points regarding the non-obstetric surgery, sir. Thank you very much. There are questions in the chat box, sir. So most of the questions they have discussed the answers in our presentation itself. We'll go one by one, sir. So the drugs which can be used safely as sedation in pregnant patients outside the operation theatre procedures.
Outside the operation theatre, under what circumstances?
They have mentioned MRI, remote area like MRI.
So if the point is same, procedure is going on in whether it is going in an MRI suite or whether you are doing a surgery on a surgical table. When you can give that anesthetic agent or sedative agent, keeping the condition, maternal condition or vitals to the normal. It is immaterial whether you give midazolam on surgical table or whether you give midazolam on an MRI table. Keeping the patient's blood pressure okay, saturation okay, giving an oxygen is good enough. So you can completely, relaxedly, very safely give sedation to a patient, pregnant patient on MRI table.
Yes, the type of drug is not important. You have to maintain the normal oxygen saturation. Yes. Okay. So another question is, which type of anesthesia is best in maintaining the uterine blood flow, whether it is GA or RA?
It's controversial. Basically, it depends on the again, as I already told in my lecture, it is difficult to prove which kind of anesthesia is more important or more beneficial for uterine blood flow, because there are some indications for regional anesthesia and there are some typical indications for general anesthesia. The point is whether we can get away without giving general anesthesia in a particular procedure, or whether we can get away giving regional anesthesia for a particular procedure. If that procedure requires general anesthesia, we have to ensure giving general anesthesia with the safest mode of delivering oxygen to the fetus. That you can ensure by giving, of course, ensuring by maternal good oxygenation, maintaining hypovolemia, maintaining euvolemia, maintaining blood pressure, and CO2 level. The usual mistake, what we do is we want to just flush out the CO2, we want to oxygenate the patient, and in giving oxygenation, we hyperventilate the patient. Be careful while oxygenating the patient. In hurry of oxygenating the patient, whether you are not doing the hyperventilation and washing out CO2, that will compromise the fetal circulation and later on to the oxygen delivery to the fetus. That is
okay, sir. Thank you. Next question is, what drugs are safe for the encirclage? It's not spinal overkill for the encirclage.
Encirclage, we are doing a lot of encirclage. We are a dedicated obstetric center. We are doing a lot of encirclages, like almost 10 circlages in a month, usually coming to us. Most of the patients, they are agree with the spinal, like saddle block, or you give a saddle block and they are happy. But some patients are so apprehensive about early pregnancy. We very safely give general anesthesia to these patients, very short anesthesia. It takes 5 minutes to take Surgeries. You induce the patient with simple glycopyrrolate or a simple analgesic like Necfin, propofol, and you maintain the oxygenation with supraglottic airway. Of course, when I say supraglottic airway, it is IGL with side lumen, with catheterized side lumen, and it is connected with the suction, keeping in mind the risk of aspiration and taking care of it. It is very safe to give general anesthesia to these early pregnancy patients, and you can get away within 10 minutes. We are done.
Okay, sir.
So both of the anesthesias are equally safely possible for cervical insufflation.
Both are safe. Okay, sir. So the nitrous oxide inhalation anesthetists, are they prone to cause miscarriages when given for a long hours?
Yes, for long hours, even because studies have not proven it. But animal studies have shown that there are some problems with the nitrous oxide. What we do if an emergency cesarean section turned up on my table and I had to give a GA, I do not open my nitrous oxide until the baby is delivered. Once the baby is delivered, I can start titrating nitrous oxide, but not before that.
So the other two questions.
For a short surgery, yes, we can like appendectomy is doing. We are doing an appendectomy. We are doing an cholecystectomy. For a short period, yes, we can open nitrous oxide. Doesn't matter if it is not the first trimester pregnancy.
So the time counts.
Yeah, time counts, and the trimester. First trimester, yes, it's better to go on opioids or any other analgesics than choosing the nitrous oxide. With the second trimester, you can add nitrous oxide to help actually reducing the MAC.
Okay, sir. The other two questions you already answered. So any precautions to prevent post-operative fetal expulsion, that is miscarriages?
See, one thing we have to understand and to convince ourselves that though no anesthetic agent per se is pro-abortive agent, they actually halt the liver. They are uterine muscle relaxant. Every time obstetrician, while operating under general anesthesia, they used to tell us, please, sir, close the inhalational anesthetic. Our uterus is getting relaxed. So how come this will act as an abortive agent? Actually, it reduces the uterine muscle irritability. It will help us. So just don't worry about using the inhalational anesthetic. You are very safe while we are. And we have the most sophisticated agent available with us, sevoflurane and isoflurane. All of them are very good. We are mostly using sevoflurane and isoflurane. They are very safe agents.
Okay. So is that fetal monitoring is essential for every surgery?
It is not essential. It is suggested, but it should be documented preoperatively and postoperatively.
Okay.
That is essential.
Thank you, sir. That's all the questions in the chat box. Thank you very much for your practical oriented presentation and also explanations. Thank you once again, sir. Thank you very much, sir.
Thank you very much, Dr. Edward. Thank you very much.
With that, we will come to the end of this session. I thank the sponsor Akrulla and our Anesthesia TV and A1 Logics. I also thank them. And next week, we are having the SARCA conference. So there will be no sessions in the next week because most of our postgraduates are attending that conference. There won't be any classes in the next week. We will meet the week next to SARCA. Thank you. Thank you, one and all. With that, we will conclude the session. Thank you. Thank you, one and all.